So without further ado, we're going to go in and discuss our faculty engagements. One of the aims of our orientation, as I've indicated, is to make sure that you see that we have parts of a greater whole, that the School of Public Health is comprised of many, many different things, experiences, and perspectives. To demonstrate this, we've invited 3 of our gifted faculty members, each representing a different academic division, to share key insights and their personal experiences. These experiences, each a different perspective, shows how we are stronger together. Our first presenter, Dr. Erica Helgeson. Dr. Helgeson is an assistant professor in the Division of Biostatistics who joined the University of Minnesota in the fall of 2017 after completing her PhD at the University of North Carolina. Her methodological research interests include developing statistical machine learning and non-parametric methods for complex high-dimensional data. Dr. Helgeson's presentation is entitled, My Journey in Public Health, Motivation, Collaboration, Iteration. Please welcome Dr. Helgeson.
Thank you for the introduction. It's a privilege to be here today and share with you my journey in public health. As I was preparing for this talk, 3 words came to mind, and these are motivation, collaboration, and iteration. And as a biostatistician, I like models, so I thought about the ways that these words are connected to each other. And that's why I have some arrows between these words there. So we'll start off with motivation. And to me, this represents your unique perspective. So this is where you come into play in this diagram I have here. So this is the background, the experiences, the perspectives that you bring into public health. So for me, my motivation going into public health is I wanted to do something that would make a difference for other people. And early on, I was interested in mathematical puzzles and scientific discovery. And so I didn't really quite know how I could bring those 2 interests together. Initially, I thought I would go into be a veterinarian, maybe like some of you thought that you would initially. And so I did a job shadow when I was in high school and saw a cat get a vaccine and passed out. Completely passed out. So decided that was a little bit too hands-on for me. So the next thing I thought about was maybe I wanted to do more science, so going into ecology and learning about the ways that we can interact with our environment. And I did a research experience in college and was out collecting snail samples and was in the middle of a pond, and a hailstorm came through, got entirely beaten down by hail, and again decided that was too hands-on for me. So what made me go into biostatistics was I was in a genetics lab, also in college, and had run an experiment and collected data, and had a spreadsheet of data and was able to pull from my mathematics and statistics classes and knew what I needed to do, what tests to run to analyze the data. And that's when that light bulb went off in my head and was like, this is what I want to do. I can make a difference, I can study health and science, but I can use these mathematical tools to do that. So that's my motivation, that's my little box there, but each of you has your own reasons for being here. And I hope you store up this motivation that you have right now, this excitement to go out there and solve those big problems. And also, I hope you share your stories too, as you're sitting with people from different divisions and different programs to share why you're here and what motivates you. So the next word we have is collaboration. And this is where your little circle there intersects with other people's circles. So if I was making this diagram bigger, you could have all of these circles all together. So collaboration is to me is really why I'm in biostatistics. I'm able to work with people from a variety of different fields. I've gotten to work with veterinary researchers, so taking that story full circle. I work with people in dental research and in transplantation, and this is where you can bring in your skills and your backgrounds and really make a difference. So you're able to solve these big problems by using the skills that you have. And the arrow back to motivation is that when you get so involved in these research projects, it increases motivation. At least that's what I've found in my experience. So while working with people on this kidney transplantation study, we realized that we wanted to identify subgroups of people who get kidney transplants, so maybe they could benefit by different treatments. And to me, I got really excited about this problem because it's a data problem, a clustering problem. And it motivated me to kind of think about some new ways, some new methods that we could develop in order to cluster these different data types. So the last word that we'll talk about here is iteration. This is a very stats and math heavy kind of a jargon term. But it really represents to me the research experience and the learning experience too. So in some more modern statistical methods, there's an algorithm that's run in a computer. And so you'll see in these papers that you read, it'll have the steps that are run in this algorithm. So step 1, do this, step 2, do this. And then at the very bottom, it'll say iterate till convergence. And so what that means is it means that the computer will keep running this algorithm, each time getting closer and closer to the answer until convergence, until it gets very, very close. And so that's what research and learning is. Sometimes that iterative step will be a big jump. So you'll have this aha moment where you know what to do and everything kind of falls into place. Other times, that iterative step is very, very small, so it won't even seem like you're progressing further. But I want to encourage you that in times where it doesn't seem like you're progressing, when you run into roadblocks, that you're still learning. You learned a new way that it didn't work, but that's still learning. And in times of when it might seem frustrating, I will encourage you to draw on your collaboration and also draw on your motivation. So drawing on your collaboration, what I mean by that is going back and maybe talking to some people from different fields. Maybe somebody in a different field has come across a similar problem and has a unique solution that could help you. As a student, I found one thing that was really helpful to keep me encouraged in my research and in my classes was to have work groups with people from different fields. So we'd all bring our homework, bring our dissertation topics together and just kind of work separately. But then when we get stuck, we just talk about what we were doing, and it was really, really helpful to me to get that encouragement and to get those new ideas. And then going back to your motivation. So when you're stuck in these problems, to remember why you're here in the first place. Remember the ideas that you have right now and that motivation that you have that will encourage you when you get stuck. And also, I find that when I'm working on problems, I get so focused that I'm just stuck there. But to go back to the big picture and maybe think about different ways that you could frame this problem, maybe you don't need to go at the approach that you initially tried. So these are just a few things to think about as you're starting or continuing your journey in public health. I find this to be a very, very rewarding field. Not only do I get to solve those intellectual problems that so intrigued me early on, but I'm also able to do something that makes a difference. And I hope you share your perspectives and that you find that talking to other people with different perspectives really helps you in your journey. Thank you.
Thank you, Dr. Helgeson. Our next presenter is Dr. Bjornberg, an assistant professor in the Division of Health Policy and Management. His research is focused on applying operations research and systems engineering engineering principles to healthcare delivery systems. He develops mathematical simulation and optimization models to improve planning decisions, scheduling, and patient flow in healthcare settings. He holds a PhD in industrial engineering and worked in practice operations at Mayo Clinic prior to joining the University of Minnesota. He currently teaches operations research and quality in healthcare within the MHA and EMHA programs. Dr. Berg's presentation is Healthcare Systems Engineering, Who Let the Engineer in the Hospital? Please welcome Dr. Berg.
Good morning, everyone, and welcome. I'm excited to be here with you today, and we were remarking at our table, I think starting this morning, that there's a strong new energy on campus and when the fall starts, and that's great. And so we attribute that to you, and so we want to thank you for all the energy that you bring here today. So I'm going to start this today by calling out two questions that I suspect are on a lot of your minds as I stand here in front of you today. One, what is someone with a background in industrial and systems engineering doing speaking at student orientation for the School of Public Health? It's a reasonable question. Two, what does it have to do with me as I start my graduate studies? These are good questions, and I hope that after our short time here together this morning, you'll have answers to both, but more importantly, you'll walk away with a better understanding of why we're all better off as a result of the differences in our backgrounds, experiences, expertise, and perspectives. So, like all of you, I'm assuming, I chose my graduate studies discipline for a number of reasons. One, pure interests. Industrial and systems engineering afforded me the opportunity to dig deep into obscure optimization problems and algorithms that kind of satisfied my analytical inclination. So that was fun for me. But at the same time, despite whatever images come to your minds of engineers spending days on end tinkering with computer code, I was much more interested at being at the front line of these problems. I wanted to be at the context, within the setting, embedded with the surroundings, and applying these methods that I was learning. And so together, industrial and systems engineering kind of afforded a nice balance for me to pursue these interests and be applying them in real contexts. Now, as I was beginning my graduate career, there was an interesting tapestry happening in systems engineering and healthcare more generally at the time. The National Academy of Engineering and what was then the Institute of Medicine had just released a joint report called Building a Better Delivery System. Now, this report was in part a response to two previous Institute of Medicine reports called one, To Err is Human, and two, Crossing the Quality Chasm. These were landmark reports, and in them, systematic failures and broken processes had been identified as key contributors to poor care and a lack of achieving the outcomes that should have been expected and associated with the technological and medicinal advances that were happening at the time. Now, a number in the community, a lot of the community, saw this as a crisis. It was certainly a threat to the overall healthcare system's ability to be productive in providing quality and efficient healthcare to all. Now, the systems engineering community took strong heed of this pretty quickly, and in the report, one of the recommendations was that medicine and systems engineering form a concerted partnership. And this is easier said than done. These are two disciplines that historically have had very disparate trajectories in terms of their research, their interests, and their overlap with each other. However, the report's recommendation and intent was that these two disciplines work tightly together in order to create and design a new healthcare delivery system that was safer and more efficient. And so this was a big opportunity for systems engineers and medicine to come together to solve some of the biggest problems. And this new healthcare delivery system was to exemplify the 6 quality aims that had been previously defined. And those are that healthcare should be effective, safe, patient-centered, timely, efficient, and equitable. Now, as momentum behind this collaboration kind of took root, there were a number of interesting discussions happening and presentations, newspaper articles were coming out, and a lot of blog posts. This is at the time when blog posts were the big thing. Twitter wasn't really happening yet. But they had flashy titles, and they were trying to draw comparisons, and this was pretty interesting. You would see headlines like, it's safer to fly an airplane than it is to step foot in a hospital. To me, that's a difficult analogy to make. These are two very complex settings that are very different from one another. And to draw that comparison was tough. But what I do think is effective with this analogy is that it articulates the underlying motivation that the healthcare sector more broadly needed to take note of the other service-based industries that were providing systems-oriented approaches in designing their services to be safe and of high quality. So, things were progressing, there were conversations happening with these two groups, and there was a need for high-level recommendations to kind of kick things off. And there were a number of very strong recommendations. First was that there needed to be incentives in order for clinical settings to implement systems engineering and other information technology-based tools in their settings. Two, there needed to be a structured process for disseminating and sharing these best practices across the entire healthcare delivery system. There needed to be new funds for research in this new collaborative interdisciplinary domain. There needed to be an effort to kind of overhaul some of the educational programs. A lot of the healthcare professional programs lacked in providing insight into systems thinking and the tools that were otherwise approachable for healthcare professionals to be using in their careers. And finally, more broadly, there needed to be an increased awareness of the opportunities and challenges that existed within healthcare for other domains that were producing analytic and managerially focused individuals in their careers. They could be partaking in this venture together. Now, these are high-level recommendations and examples of where the interdisciplinary domain was going, but at a more tangible level, things started to come to fruition. A number of more recent examples of how these two domains collaborated with each other include the design of new sophisticated scheduling systems that helped reduce delay and improve patient access to care. New pharmacy management systems were reducing errors and improving availability of rare and expensive drugs. New operational models were designed in order to support triaging and decision-making in very volatile healthcare environments, such as the emergency room and urgent care clinics. These contexts are very difficult to manage because of their highly uncertain and dynamic demand. Here at the University of Minnesota's Clinics and Surgery Center, there's great examples of what's happening in this cross-disciplinary domain. Patient and provider interactions are monitored using real-time locating technology, and this gives operational managers a brand new bird's eye view of the entire system's behavior across the entire clinic in real time. And so this is very exciting. It gives them, or it affords them the opportunity to make dynamic reallocation of resources and staff to where they need to be in the clinic in order to reduce the backlogs, mitigate any concerns about patient congestion, and just improve the efficiency of patient flow. So these are very exciting examples of where systems engineering and medicine, two historically disparate domains, are coming together and making real change within the healthcare delivery system. However, I would be remiss to say that all of the objectives outlined in this report have been achieved. To the contrary, in fact. The Institute of Medicine recently released another report highlighting and asking for additional dedication and attention given to improving the processes which afford timely access to care for patients. This is a growing challenge and one that is observed nationally. You may remember a few years ago this was highlighted by a VA in Arizona where patients were experiencing substantial delays and waits to care to see their provider. So there's a lot of work to be done and a lot of challenges that exist. However, what I would posit here today is that the advances that have happened are evidence of what can happen when two different perspectives, two different domains, focus their attention on some of healthcare's biggest challenges and provide novel solutions to improve the system as a whole. Now, I'll bring my attention back to today and the collection of people in this room here that surround us. I think it's striking, if only momentarily, to take note of the differences that are here today in our backgrounds, experiences, expertise, and perspectives. Think about that. Think what you are all bringing to the table. This is a substantial moment and an opportunity to collaborate with each other. As you set off on your graduate careers, keep this in mind. As you advance not only your own, but the domain's knowledge, draw from the surrounding disciplines around you. I would argue that future public health leaders will be better off and more productive by bringing different disciplines to the table and drawing from different perspectives in order to strengthen their solutions. Now, the example I talked about here today, where systems engineering and medicine came together and provided new solutions, is one that was in part initiated at a very broad and national level. The stage was kind of set by two national academies setting a very broad agenda and a call to arms, so to say. But this needn't be the case. Think about the opportunities that surround you here in your programs, in the School of Public Health, and at the university. Draw from those differences and improve your own work and yourselves. So I'll end today by saying a few things. One, I hope I've quelled some concerns that you may have had about needing to listen to a systems engineer attempt to talk about healthcare and public health more generally. But more importantly, I hope that you do take note of how these two vastly different domains have made a concerted effort to partnership and come together and tackle some of healthcare's most vexing problems. So I'll end today by saying that I hope your time in the School of Public Health is as engaging and welcoming as mine has been. I hope you find your peers, the staff, the faculty to be as inspired and collegial as I have found them to be. And finally, I hope you find the differences that surround you to be as strengthening and enabling to both you and your own work as I have found them to be. Thank you.
All right, our final presenter is Dr. Marisa Ramirez. Dr. Ramirez is an epidemiologist by training with experience in mixed methods and intervention evaluation. She has conducted school-based research since the 1990s to study injuries to school children, disaster preparedness in schools, and school violence. She has evaluated a number of public health prevention and intervention strategies, policies to prevent and respond to face-to-face and cyberbullying, school and hospital-based programs of psychological first aid and trauma-informed care, disaster preparedness programs, and policies and parent-based programs to prevent roadway traffic crashes, especially among teens from rural communities. Dr. Ramirez's presentation today is her personal path to choosing violence prevention as her field of work, and how violence is a public health priority that impacts marginalized, underserved populations. Please welcome Dr. Ramirez.
Good morning, everyone. So let me start with a question. How many of you have been in a car crash? How many of you know someone who has been killed in a car crash? Okay. And this one, you can choose to not raise or raise your hand. How many of you know someone who's been killed by homicide? I'd like to share with you a story. This is Grace Assumption. She was 20 years old. She was killed in 1992 on the UC Berkeley campus when I was a college freshman. And her murder occurred in a building that was to service various student minority groups. She was a member of the Filipino American Alliance, a group that I was a member of. As a freshman, I was looking to the Filipino American Alliance as a place that would be home to me, that would be a safe haven, that would be a voice and faces who would be familiar and who would be welcoming. She is the only person that I have known who has been killed by violence. Her murder was unsolved for 20 years. She was sitting in that student office, often studying in the middle of the night. Lots of traffic coming in and out of this particular student building. And then she was found stabbed to death by custodial staff on a Friday evening about 6 p.m. Her murder was unsolved for about 20 years. And just in 2016, they identified an individual who was on psychedelic drugs who walked onto campus and who had killed her. Now, you know, I think about my path and how, and what grace represents to me. I didn't think as a freshman that I would be studying violence prevention or injury prevention. In many ways, you look to those points in your life and think about how they perhaps influenced you subconsciously. But as an epidemiologist now, as I look at data and I study statistics, and I thank my colleague Erica about sharing her journey about mathematics, grace is the face that I think about when those data speak to me. And I know that we weren't supposed to share too many slides and provide too much information about data, but I felt it was important that I share why injuries and violence are a public health issue. These are data from the Centers for Disease Control and Prevention. Do many of you know that injuries and violence are the leading cause of death for ages 1 to 44 in the United States? Okay, some of you do know that. And many of you are in this age group, so you are more likely to die from injuries and violence than any other cause of death if you are within that age group here in the United States. And in fact, when we think about injuries and violence, and let me focus specifically on violence. So violence is a form of injury that is intentional. There are 3 general forms of violence. There's interpersonal violence that occurs between individuals. There's self-directed violence that occurs when one inflicts violence towards themselves. And there is collective violence, and when groups of individuals, often politically, theologically motivated, incur violence towards each other. When we think about these 3 forms of violence, suicide is the 10th leading cause of death in the United States. The 10th leading cause, okay? And in fact, over 45,000 Americans die of suicide in the past year. There's been a significant increase, about 30%. And while there has been discussion in the media about mental health concerns and its connection with suicide, only about 50% of suicides have some type of mental health relationship. Okay, so these are staggering figures. When we think about interpersonal violence, homicide is the 15th leading cause of death in the United States. Okay, so, and I'm talking about, these are just, you know, the deaths, which represent the top of the spectrum. When we think about injury-related deaths, for every single fatality, there are 30 non-fatal events that occur. Some of these leading to lost work time, okay? And then for every one of those, again, those single deaths, there are about 300 incidents of injuries and violence that result in hospitalization or contacts with our hospital system. So there's a huge burden on society. I also show here a couple of other figures because I think it is important to think about other forms of violence that we hear about, that's been talked about, particularly in the media. So that second figure right here, nearly 1 in 4 women, about 1 in 4 men report experiencing severe physical violence with an intimate partner in their lifetime. Okay? So 1 in 4 women, 1 in 7 men report either being physically assaulted, being raped, being stalked by an intimate partner. Okay? And many of these incidents actually don't show up in the statistics, that are collected by the Centers for Disease Control and Prevention. These are statistics on the deaths, on the ones that are hospitalized. We have the best data on that. So much more is unreported. And then finally here on the left-hand side, and this is an area of work that I've been working in, is in bullying. About 20% of high school students in the United States report being bullied at school. It is the most common form of peer-to-peer violence in the United States and across the world. So the question comes in public health, what is the role? What is our role in addressing these issues? Okay? And we think about, this is the spectrum of public health prevention, from surveillance, that's understanding what are the trends. How prevalent is violence? Do we collect accurate data on violent events? And the answer is not really. We probably collect best data on deaths, somewhat, but we really don't have good data on these relationships, on mental health issues, on some of the outcomes, such as how much lost work time, what was the disabilities that might have been experienced. So we need to work particularly in that area. Now, once hopefully we have good data to identify these trends, identify the burden, then we think about risk factors and protective factors. What factors are leading to increased risk of violence? What factors protect against violence? Once we know that information, then we think about interventions and identifying strategies that can help reduce and prevent violence from occurring in the first place, and also responding to violence. So are there policies that are most effective in bullying prevention? Are there educational strategies used in school settings, in hospital settings, in workplaces that address intimate partner violence? Are we coming up with community-based strategies to help those who are at risk for suicide? So these are the questions that we ask ourselves as we go through this path through public health. And then finally, once we identify the best strategies for prevention, what is our job in disseminating and making sure that the most effective strategies, the evidence-based approaches, are actually being utilized? And that's a challenge that we've encountered particularly in communities. And I think about the best example is the DARE program. Do you all remember DARE? Went to school? You had the police come into your school, talk about drugs, and the goal was to prevent drug use. Well, data had shown that such a program was not effective, and yet millions of dollars had been put into place to address drug use. So the question is, are we doing our job to get the information out there? Are we reaching the communities, the school settings, the communities, the organizations that identify strategies and put them into place? And we can certainly think of other examples in bullying prevention in which strategies have been developed in Europe, brought to the United States, and then found to be ineffective, particularly for people of color. Okay? So it is our job to identify the most effective strategies and then test them and provide the information for dissemination and implementation. Now, I want to kind of pause here, and you will all learn this through your journey in public health. You will go through the courses that talk about surveillance, about risk factor identification, about evaluating interventions and disseminating them. Okay? And as I have done this work for the past 20 years, what I still struggle with is this concept or the lack of understanding that violence is a public health issue. Okay? And I had read a few articles that were published in Forbes magazine, for example, and other media outlets that called violence a, quote, phony public health crisis, or said, violence is not an epidemic, it's a metaphor. Have you heard these discussions before, perhaps? And then it becomes extremely political because of issues regarding the Second Amendment and right to bear arms when we talk about gun violence. So why would this not be a public health crisis? When we talk about epidemics and we think about 30,000 Americans killed from firearm violence, where this leads to use of the medical care system, right? Hospitalization, visits to emergency rooms, visits to primary care physicians. This leads to disability and lost work time. Why would this not be a public health crisis? And I'm not here to say I'm for or against the Second Amendment. It's about providing the best data possible to answer the questions about what works and what doesn't work in prevention. And I absolutely believe that we need to talk to firearm owners and understand what are safe practices for firearm ownership. I lived in Iowa for 9 years, and I have a great deal of respect for the hunting community. And I think we need to come to the table to have those conversations and really kind of ask this question as to whether or not gun violence is a public health issue. And we actually don't have enough data to identify what strategies work and don't work. So as you go through your journey and identify the topics that mean the most to you, I think it's important to remember two things. Number one is behind the data, behind the statistics, there is a face. There is a person, there are people, and we do look at population-based, large population-based efforts in public health prevention. But there are individuals, and whether or not you can tell your story from the face or the voice of Grace or others that you may know who have been impacted by the health issues that you choose to study, that will be important in telling your story. The second point is that we will come with questions. People will come with questions, maybe challenge our data, challenge our findings. And as academics and as graduate students, you will be challenged by your professors, by your peers. We're challenged by the folks in the media, by politicians. And I say, walk close to that line, present your data. Your data won't lie, your results won't lie. And if you're truthful to that, then you can tell your story. You can advocate for what you think are the strategies that will work to raise the bar and identify approaches that will help save lives, because that's why we are here. We are here in public health to prevent disability, to prevent death, to prevent pain, and to prevent suffering. Thank you.
Thank you. That is just a sample of 3 of your outstanding faculty members. There are many more. This is why I hope many of you are here, to really learn from 3 people just like this.